Arteriosclerosis is the thickening, hardening, and loss of elasticity of arterial walls. Arterio refers to arteries and sclerosis means hardening. Now, since it is the arterial wall thickening, so it will depend on which artery is affected by this pathology. So, if we have, say, it is an artery supplying a muscle, that muscle will undergo sudden weakness. Say the artery is supplying the face, so we're going to have jaw claudication and facial numbness. Say the artery is supplying the lower limb, it is going to cause lower limb numbness, etc. If the artery is the carotid artery supplying the head region, the brain, we're going to have confusion, difficulty understanding, speech, and sight problems. Now let's see what are the three pathologic patterns of arteriosclerosis. Now these three terms need to be very well understood and differentiated from each other. First of all, we're going to talk about atherosclerosis. Then we're going to have arteriolosclerosis. And then we're going to have Monckeberg's medial calcification. Coming to atherosclerosis, whenever you see athero, that means it is referring to an atheromatous plaque. Now, I'm going to tell you in a while what an atheromatous plaque is. Now, atherosclerosis is a chronic, means over a long period of time. It is an inflammatory condition, means all of the stages of the inflammation are going to be present. It is also a healing response, that means the healing aspect of inflammation is also going to be present there, and it is going to be caused by endothelial cell injury. So, atherosclerosis is a chronic inflammatory condition and healing response of the arterial wall to endothelial cell injury. Now, this endothelial cell injury is going to be caused by a number of reasons and risk factors. Coming to the risk factors for atherosclerosis, they can be classified as being non-modifiable, modifiable, and additional risk factors. Non-modifiable are also known as constitutional risk factors because you can't really do anything about it, sadly. But it's okay, there are a lot of things you can do about the modifiable risk factors, but you probably won't do them either. The first non-modifiable risk factor is genetics. Now, family history is the most significant independent risk factor for this disease, and there can be familial hypercholesterolemia, which means that your blood is going to have higher cholesterols, and the risk for formation of atheromatous plaques will be very high. Secondly, you can have genetic polymorphisms, which can account for increased predilection for hypertension and diabetes, which is also very sad. The second non-modifiable risk factor is the age of the patient. So classically, the age between 40 and 60 is very prone to develop atherosclerosis, and generally, as a rule, the more the age, the more you're prone to develop this. And one thing to remember is that atherosclerosis is a chronic process, and it starts very early on in the life of a person, and even children are going to have thin plaques in their endothelium. The third risk factor is gender. Sadly, like everyone else, atherosclerosis also likes to discriminate on the basis of gender, but in this case it's slightly odd because females are having an advantage, and females before menopause are less prone to develop this disease. Why? Because the hormone estrogen that they have before menopause is thought to be cardioprotective. Secondly, we have many modifiable risk factors for atherosclerosis. So the first modifiable risk factor is hyperlipidemia and hypercholesterolemia. That means you're going to have higher levels of lipids and cholesterol in your blood than normal. So this is a very high risk for development of atherosclerosis, and in this case you're going to have increased LDLs, that is low density lipoproteins, and decreased HDLs, which is a high density lipoprotein. HDLs clear the blood of the lipids by increasing their metabolism, while LDL is the bad cholesterol. So there are many ways you can modify this risk factor by decreasing your levels of the lipids in your blood. By many ways, you can use drugs like inhibiting cholesterol synthesis, statins. You can also use lifestyle changes and generally adapting a more healthy lifestyle. Secondly, The second modifiable risk factor is hypertension. Now, hypertension has been strongly linked to the development of atherosclerosis. Why? Because you know that atherosclerosis starts developing once there is an injury to the endothelial cells, and hypertension, since it causes high pressures in the arteries, and also the high pressures are going to cause turbulence in the bloodstream and cause damage to the endothelial cells, and thus they are more prone to developing atherosclerosis. Also, the risk for atherosclerotic ischemic heart disease in hypertensive patients is 60% more than those who do not have hypertension. Thirdly, smoking is also a modifiable cause. You can always quit smoking, but then you cannot. Diabetes mellitus is also a risk factor for atherosclerosis, because the hyperglycemia, it sort of also disrupts the homeostasis of the endothelial cells and accelerates the development of atheromas. Additional risk factors like inflammation due to any cause, actually due to some infection or some autoimmune disease, that does not matter, but this is an additional risk factor. Elevated levels of homocysteine are also linked with atherosclerotic disease. In this case, the patient is going to have low folate or vitamin B12, or this can also be genetic. Thirdly, metabolic syndrome is a constellation of obesity, hypertension, glucose intolerance, dyslipidemia, and pro-inflammatory state. So when a person has all these bad ill effects already, so he or she is more prone to atherosclerotic disease. Next, we have lipoprotein A. Now, lipoprotein A is actually a part of LDL. If you study the structure of LDL, lipoprotein A is a part of it, because LDL is low density lipoprotein, and lipoprotein is lipoprotein, that is understood. Okay, so when there is raised levels of lipoproteins, it is also linked to raised levels of LDL, and thus raised levels of cholesterol, and thus increased risk for atherosclerosis. Next, we can have factors which affect the homeostasis of the body and disrupt all over function. Okay, so the other causes or other risk factors for atherosclerosis can be type A personality. Now, type A personality means those people who are workaholics. They put too much pressure on themselves, and they're anxious, they're too proactive, but in a bad way. So those people are at high risk. And type B personality, which are in contrast to type A, which are more relaxed, they are more docile and flexible, so they are good to go. Obesity is also a risk factor. Coming to the pathogenesis of atherosclerosis, or to know that how do these atherosclerotic lesions form, we first need to see that the main reason that these plaques are initiated is due to endothelial cell injury, insult, either loss of endothelial cells or dysfunction of endothelial cells. So there can be a number of processes which can cause this endothelial cell injury or insult. Now, elevated levels of cholesterol or lipids, how do they cause endothelial dysfunction is by local oxygen-free radical formation. So once these free radicals are formed, they cause the LDL to be converted into oxidized LDL, and this oxidized LDL is particularly directly toxic to the endothelial cells and also the smooth muscle cells of the vessels. So this is one way in which there can be endothelial cell insult. Secondly, we can have hemodynamic disturbances. That means turbulent blood flow. Now, usually, though these other factors such as hypercholesterolemia or hyperlipidemia or smoke or hypertension, toxins, infections, all the other causes are uniformly distributed, but still atherosclerotic plaques are not present everywhere in the vasculature. Why is that? Because one of the factors is turbulent blood flow, and this mostly occurs at branch points. For example, if this is a vessel, as long as the blood is flowing in this vessel, even if the patient is hypertensive, there might not be that much turbulence. In the cases where this is going to branch, then these areas are subject to turbulence, and mostly the branch points of arteries are prone to atherosclerotic plaque development. So, turbulent blood flow, they activate genes in the endothelial cells to increase the chances of plaque formation, and thus this is another factor. Smoking, as I said, is one of the etiologies, and this is going to directly affect the endothelial cells. Hypertension will cause turbulence, and the high pressures can also directly affect the endothelial cells. Toxins or immune reactions, autoimmune reactions, can also affect the endothelial cells. Infections such as herpes, cytomegalovirus, chlamydia, all of these have been linked and found in the atheromatous plaques. Now, that is not clear if they are causing this, or they are also very common. These are common pathogens, so we're not very sure if these are causing this or they're generally present. So, once there is endothelial insult, either loss or dysfunction, now normally we know that the endothelial cells are responsible for keeping the blood in a liquid state. That means it sees whether coagulation is needed or not, and if coagulation is not needed, it destroys the clot that it has formed. That is the normal function of endothelial cell. But in this case, when the endothelial cell will be subject to injury or loss, it will increase the procoagulant activity, and there will be platelet adhesion, and the anticoagulant activity of the endothelial cell will be decreased. So all of this will cause accumulation of platelets, RBCs, and other substances in the blood vessel wall, in the intima, and will contribute. Apart from platelet adhesion, there will also be activation and recruitment of inflammatory cells. Why is that? Because the endothelial cells have been injured, and injury causes inflammation. So dysfunctional endothelial cells will express increased levels of VCAM, which is vascular cell adhesion molecule 1. This will also cause increased proliferation of T cells and macrophage activation within the area. Thirdly, as I said before, the increased cytokines locally, that is, these might be produced by the T cells and the macrophages, and smooth muscle cells synthesis. The precursors of smooth muscle cells can be derived from within the circulation and also from the vessel wall media. All of this will cause increased smooth muscle synthesis and increased extracellular matrix synthesis. The growth factors which are mainly responsible for this are fibroblast growth factors, TGF alpha, and platelet derived growth factor. All of these will cause the proliferation of smooth muscles and extracellular matrix synthesis. As I said, regardless of the cause of endothelial cell injury, what happens is that in the intima there is lipid deposition, and we can see these fatty streaks in the intima of the arteries. So what happens is that since inflammation has ensued here, and inflammation always recruits monocytes to become macrophage. So these macrophages are going to engulf and sort of eat up the lipid and convert into foam cells. Okay, so these foam cells are going to be formed, and they are characteristic of atheromatous plaques. After the formation of these foam cells, simultaneously other processes such as increased cytokines production is also going on, as I said here, and these are not separate processes. I've only separated them for the sake of understanding, and all of these processes are going to be occurring simultaneously. So we're going to have increased smooth muscle synthesis, increased extracellular matrix synthesis, increased T cell and macrophage activation, increased procoagulant activity, and what will happen is that also, since these are inflammatory cells, they will start degrading the smooth muscles of the media, and extracellular matrix will also be degraded. So since the inflammatory cells are sort of going into the vessel wall, so they are going to get hyperexcited and eat away everything they encounter. So we're going to have unstable plaques. Why? Because the plaque is developing from the vessel wall, right? So when the inflammatory cells come and eat up this, so this plaque will always be unstable, and it might rupture, or it might rupture, and after the rupture there will be procoagulant activity and clot formation and thrombosis and embolism and all sort of bad stuff. Regarding the morphology of a typical atheromatous plaque, grossly it is seen as a raised white-yellow entymal-based lesion, while microscopically it is going to have three distinct parts, say. First one is a fibrous cap which has smooth muscle cells. It is going to have foam cells. It is going to have lymphocytes. It is going to have elastin, fibrin, and that's why it's called fibrous cap, and also new vessel formation. The second part is going to be the necrotic center. It is going to have foam cells, lymphocytes, cholesterol crystals, and all the dead cell material, which is the products of the inflammation. And lastly, we're going to have a smooth muscle media, which we do have normally in an arterial wall, but in this case, this smooth muscle will be getting degraded by the inflammatory cells that are present here. Now that was the structure of a typical plaque, but what if we have a complicated plaque? A complicated plaque is that which has undergone calcification, hemorrhage, fissuring, or ulceration. Why is it called complicated? Because it can result in local thrombosis. It can cause cholesterol microemboli. Since it has ruptured, all of this necrotic core will go out and cholesterol crystals will go out into the circulation and cause microemboli. There can be medial thinning, as I said, that the smooth muscle media is going to be eaten up by the inflammatory cells, and this will cause aneurysm formation and dilation. The consequences of an atherosclerotic plaque are stenosis, acute plaque change, vasoconstriction, thrombosis, and aneurysms formation. Number one is stenosis. Now, it is very clear that since this plaque is formed in the lumen of the artery, it will cause stenosis. This stenosis is going to cause downward ischemia and cause tissue atrophy, infarction, or simply ischemia. Now that will depend on the degree of stenosis and at which rate the narrowing is occurring, and also on the metabolic demands of the affected tissue which the artery is supplying. Now in the early stages of stenosis, we have an adaptation that the smooth muscles of the media does. What is that adaptation is that, for example, if we have a atheromatous plaque here, what it does is that it sort of the smooth muscles here are going to proliferate and make space for this plaque to accommodate it in such a way that it will not be here anymore, and the luminal diameter is going to be preserved. So this is accommodation that or adaptation that the smooth muscle cells of the media do in the early stages of the stenosis. But if the artery is 70% stenosed, which is known as critical stenosis, then the vascular supply is inadequate, and then there is no chance of adaptation and ischemia will ensue. Now, in most cases of myocardial infarction, the plaque itself is not that large in size to cause stenosis and downward ischemia. What happens is that the plaque that is present in the coronary arteries undergoes rupture and thrombosis, and that is what causes the acute MI. Okay. Now, we have two types of plaques. One is the vulnerable plaque, and the second is the stable plaque. Now, to know about the distinctions between the vulnerable plaque and the stable plaque, we're going to have to see this diagram again. The vulnerable plaque is going to have a thin fibrous cap. The necrotic center of this plaque is going to be large and easily deformable, and the smooth muscle media of the wall is going to be constantly degraded by the inflammatory cells, and the inflammation in this case is going to be very high. While in the stable plaque, all of this is going to be the opposite. The fibrous cap is going to be thick, and it is not going to be easily penetrable. The necrotic center is going to be small and stable, and the smooth muscle media or the inflammation, overall inflammation, is going to be low and not that high. Next is vasoconstriction. Now, why will be vasoconstriction occurring? We know that the endothelial cells normally produce nitric oxide, which is a vasodilator, and when endothelial cells are disrupted, the nitric oxide won't be produced, and also vasoconstriction can occur due to the spillage of all the necrotic core contents, and generally the area will be disturbed, and that can cause vasoconstriction as well. Thrombosis, as I explained, that due to the rupture of the plaque there will be local clotting, and that will cause thrombosis, and it can also dislodge from there and cause an embolus. Aneurysms will be formed because of the smooth muscle media degradation by the inflammatory cells, and once the media is thin, the muscle content will be low, and that area will become weak, and the high pressures of the blood will cause ballooning of the area called an aneurysm. Okay, so that was all about atherosclerosis. Now we're going to see arteriolosclerosis. That means arteriolo means it is going to involve the hardening and narrowing of small arterioles. Now we have two types of arteriolosclerosis. One is hyaline arteriolosclerosis and the other is hyperplastic arteriolosclerosis. Now, why does hyaline arteriolosclerosis occur? What happens is that there is going to be endothelial cell injury, and we know that whenever there is injury, there is high permeability, and all the plasma proteins and the plasma contents are going to leak into the vascular wall, and that is going to cause the hyaline appearance on the microscope. Diffuse pink hyaline arterial wall thickening will be seen on microscope because of that. There is also going to be increased smooth muscle matrix synthesis. Now, hyaline arteriolosclerosis is chiefly associated with diabetes mellitus. Why? Because we know that hyperglycemia causes endothelial cell injury. Whenever this hyaline arteriolosclerosis is mentioned, you should think about kidney. This is the most common site where this occurs, and that is chiefly in the kidney glomeruli. When in kidneys, it will cause ischemia, and that will be known as arteriolonephrosclerosis. That means that there will be glomerular scarring because of low blood flow, and this is a slow process which will cause chronic renal failure. So next is the hyperplastic arteriolosclerosis. It is known as hyperplastic because there is hyperplasia of cells. Which cells? Smooth muscle cells. Exactly. So why does this happen? This happens in malignant hypertension. Now, I've told you guys in the previous video that malignant hypertension is the sudden extreme rise in blood pressure. So when that occurs, I also mentioned that it results in end organ damage, and chiefly kidney is affected in this case. So what will happen is that since it is a rapid rise in blood pressure, and in order to accommodate that increased pressure, the smooth muscle cells of the arteries undergo hyperplasia in the form of concentric laminated arteriolar thickening. Since it is malignant hypertension, which is an acute phenomena, that's why the renal failure will also be acute, and this has a characteristic flea-bitten appearance. So the last type of arteriosclerosis that we have is Monckeberg's medial calcific sclerosis. This name shows all the details except for this, of course. Medial means smooth muscle media of the arterial wall, calcific means calcification of the smooth muscles of the media of the arterial wall, and sclerosis means hardening and loss of elasticity. So what happens is that this is actually dystrophic calcification. It is not due to hypercalcemia or something. It is due to old age and generally damage to the arteriolar walls, which will cause the deposition of calcium in the walls. Okay, so under the microscope, it will show us ring-like calcifications in the media because media has ring-like smooth muscles. Now, since this is not in the intima and it is only affecting the media, and it is calcification, which is simply a deposition, so there is no obstruction, and that means if there is no obstruction, this phenomena is not significant clinically. Okay, it is only found accidentally on mammograms when we know that breast cancer needs screening, and every woman above the age of about 40 to 45 should have mammogram once a year, and this is going to be an accidental finding on mammogram, and it is not clinically significant. It is also seen commonly in radial and ulnar arteries. Coming to the diagnosis of this condition, arteriosclerosis, the major problem here is atherosclerosis. Okay, so firstly we can diagnose it on the basis of a physical exam. How is that possible? As I said earlier, that the artery which has undergone atherosclerosis is going to be supplying some organ, right? So when that organ undergoes ischemia, it is going to show clinical symptoms, and that can be picked up by a physician. We can also do a cardiac CT and MRA, which is an angiography but a magnetic resonance angiography. We can also see blood tests and check the levels of fats, cholesterol and glucose, proteins, etc. to see the risk and also to have a clue if this is going to be atherosclerosis or not. Lastly, the treatment of these diseases, chiefly I'm talking about the treatment of atherosclerosis, okay? The medical treatment can be by using cholesterol-lowering medications such as statins and fibrates. To control hypertension, which is a risk factor, we can use ACE inhibitors. Beta blockers and calcium channel blockers can be used for the same reason. Diuretics also. Anticoagulants and antiplatelet drugs can also be used to stop the coagulation. Of course, aspirin is also having an anticoagulant activity. There can also be surgical solutions to this problem that include bypass surgery, thrombolytic therapy, which is surgical because we can also use thrombolytic drugs. So what we can do is that during surgery we can target the particular artery which has the plaque and inject thrombolytic medication into that directly. We can also do angioplasty. We can do atherectomy. Atherectomy is simply a non-invasive. It is invasive. It is a surgical procedure, but it is minimally invasive. And what it does is that it is going to put a catheter into the artery and destroy the plaque in some way by laser or by tiny blades which are rotating and stuff like that. And lastly, end arterectomy, which means that the plaque is separated from the intimal wall by some way surgically. That was pretty long, I know, but what can I do? See you in the next one.